All right, we're moving on to the next subject matter in cardiac pathophysiology, which is hypertension. Hypertension is actually a very common problem. What I'm going to sort of do is to go a little bit over the physiology of it. So we can go over what is blood pressure, and we're going to go over and discuss how is blood pressure actually regulated, just briefly. We've already talked about it in physiology. Then actually the different forms of hypertension and medications that are used in the treatment, because that's become also in pharmacology, but I think it's also important to stress again. And then one of the major things that we ever have to deal with is hypertensive crisis, and something that may actually occur in the operating room, which is pretty critical, and you need to be able to take care of it properly. Blood pressure is basically the pressure within the blood vessel as a result of the amount of blood that's actually being delivered to that vessel, which is directly related to cardiac output, which is a very important start point. The second thing is the area of the actual vascular surface. The area of the vascular surface doesn't really change for most individuals in an acute stage. It pretty much stays consistent. Where you can see a tremendous increase in vascular surface area will be somebody who develops morbid obesity. Okay, for every single ounce of adipose tissue that you add, you're adding more vascular surface area, and as a consequence, the resistance is going to go up. So you see a lot of people with morbid obesity have developed significant hypertension over time. The other major important factor besides cardiac output regulating blood pressure is peripheral vascular resistance. And peripheral vascular resistance has to do with the actual smooth muscle tone. And it could also be affected by external compression effects. And again, length of vessel is also would be an important factor if persons could vary their length of vessel, which they don't. So in essence, it's a theoretical concern in the back of your mind, but it's something that you shouldn't be worried about for that individual. The major factors that really control blood pressure are cardiac output and peripheral vascular resistance. Now, the organ systems that are involved in blood pressure regulation are basically your heart and the blood vessels, because it's a closed circuit. Okay, and that's what most people think simply in their mind. This is the simple cardiovascular system. But there's a lot more organs involved in that. Okay? The heart's just responsible for the cardiac output, which of course we'll talk about in a little bit. It's what affects cardiac output. And the blood vessels have to do with mostly vascular resistance. But if you look at the other organ systems that are involved, ultimately what actually depends on how much volume you have in your body is dependent on the kidney. The intravascular volume is controlled by the kidney, and as a consequence has long-term regulation effects and long-term hypertensive effects as well. The central nervous system, of course, is the main system that regulates your autonomic nervous system, and that can actually go out of whack in certain situations and cause hypertension as a result. And the humoral mediated system, which is regulated partially by the brain, which is things like ADH and adrenocorticotropic hormone, also is affecting the adrenal glands, which are both the adrenal the cortex as well as the adrenal medulla. Both secrete hormones that will affect your blood pressure balance in your body, and ultimately your kidney as well releases hormonal regulatory mechanisms as well. Now, when you look at, first of all, let's look at the cardiovascular system and look at what controls cardiac output. And cardiac output is basically heart rate times stroke volume. So what regulates heart rate, you got to make sure you have a regular rhythm. Neuroregulation of that, which we talked about previously, which is sympathetics and parasympathetics. Hormonal regulation that affects heart rate can also take place. So you have long-term regulation such as adrenal medulla, which releases epinephrine, as well as norepinephrine. And thyroid, of course, can also alter your heart rate. As for the other important factors, not all here, but the next slide, preload is the first one we're talking about here, is volume returning to the heart. And you can see how many different things can actually affect your preload coming back. You have your neurovascular resistance regulation, which is sympathetically driven. You have your brain hormonal humoral regulation, which is ADH. Your renal humoral regulation, which includes sympathetic activation, which leads to renin-angiotensin II release. You also have cardiac hormonal volume regulation, which is the adrenocorticotropic factor. Your adrenal cortex is also important in releasing the cortisol and aldosterone, especially aldosterone. Thirst, which is a brain-driven event. Positioning of patients as well can actually significantly affect preload return. Gravitational effects, which is G-forces, and of course compressive forces on the patients. And it's all things you have to consider about actual preload return. So preload is actually a fairly complicated concept, with many, many different factors that can affect preload return back to the heart. The other two factors, of course, that affect stroke volume are going to be contractility and afterload. The contractility component of it is regulated depending on which portion of the heart you're looking at. At the atrium, you're looking at the neuroregulation is both sympathetic and parasympathetic, versus the ventricle itself is a purely neurally regulated sympathetic driven system. So contractility can be affected in the atrium by vagal reactions, but when you look at the actual ventricle itself, it's not affected in its contractility at all by the actual parasympathetics, and only sympathetics are responsible for it. The adrenal medulla also releases hormonal regulation, which things sends out norepinephrine and mostly epinephrine that increases contractility velocity. The other important part of contractility could be also ionized calcium levels, which most of the time is pretty well heavily regulated, usually not a problem, but sometimes in acute settings you can get into low ionized calcium levels, especially when you're giving a person multiple drug transfusions, and you can drop the ionized calcium levels to critical values and affect contractility. And of course, oxygen levels are very important for contractility. As for afterload, afterload is affected by many, many factors. Valvular effects alone, aortic compliance, and that varies between the age groups of individuals, and we'll show you that a little later. Blood viscosity is also an important factor, as well as arterial resistance. By far, what we consider most of the time when we're looking at afterload is we're looking at arterial resistance. Now, unfortunately, people forget this second one here, which is blood viscosity, which I think is pretty important for us, because you can actually do a case and you have somebody with normal vascular resistance, and if you actually were to actually looking at the actual arterioles and see their tone, they would actually be normal or actually a little higher. And if somebody's bleeding out on you and all you've done is replace them with crystalloid, you'll find out that the blood viscosity is dropped by about 50%, and all of a sudden that same amount of blood volume that you would have in that individual with the same arterial resistance, your blood pressure is actually halved. And it's simply because of the drop in the actual blood viscosity. So the only thing you can actually do at that point is to replace that viscosity is to give the person cellular units, which is, in this case, giving that person packed RBCs. And you can see a dramatic change in people's blood pressures. They seem to be non-responsive to therapy, and you give them 1 or 2 units of blood, and all of a sudden the blood pressure comes back to normal. And most of the time, that's usually due to blood viscosity issues. And when you check your hemoglobin and hematocrit, you're looking at maybe in the values in the 20s or lower. So those are the kind of times that you really need to consider that you should be giving blood at that point, and really consider giving the trauma blood at that point, which is O-type blood. Now, what affects vascular resistance, which is the second component of the actual blood pressure regulation, is another thing that's complicated. The reason I'm showing you all these things in sort of review is when you talk about hypertension is that you've got to keep in mind that this whole system is something that's pretty complicated. And a lot of times when we don't identify what the main cause is, it could be a breakdown in any one of these systems. Okay? So sometimes it's more than just one system. It's maybe multiple factors. But vascular resistance is very importantly regulated by local regulators, which is the endothelial cells of every single blood vessel in your body releases certain kinds of compounds that affect the vascular tone around that area. And things that will actually inhibit and cause relaxation of the smooth muscle and cause basically the area to vasodilate will be things like nitric oxide. Patients that are developing increasing levels of hydrogen ion, which is basically a sign of metabolic acidosis or signs of stressor. You want the area to be flush with blood flow, so that would be a good way to negatively inhibit the vascular tone and allow now the blood flow to return. Adenosine is one of those also byproducts of increased metabolic workload, especially by the heart. So coronary blood vessels secrete a very large amount of adenosine under points of stress to make sure that the coronary blood perfusion is at its maximum. Prostaglandins are also inhibitors. Things that actually will reverse that effect is once you get very oxygen-rich blood to that area, the negative feedback mechanisms will shut it down. Will start causing the muscle to contract a little bit more. So oxygen actually causes vasomotor tone to improve. Endothelin will also basically cause vasomotor tone to increase. The only neural input that you have at the vasomotor area is sympathetics. That's all you have. You have no parasympathetic activation at all. So if you look at your total body sympathetic, total vascular resistance, it's due to sympathetic nervous system, which means something really important to you, okay, especially in anesthesia. Okay? The main mechanism is that it's in the thoracolumbar area, okay, of the spinal cord. It is not the brain that's regulating, and it's not the cervical area. Okay? It means you have to have an intact thoracolumbar area for you to have a normal blood pressure. So anything that interferes with the thoracolumbar, which is the anterolateral area of the sympathetic nervous system, you can actually cause a very deep vasodilation to take place and cause a person to go into shock. Okay? So that's always to keep that in the back of your mind. That's really a pretty important concept, especially for what we do. When we do spinals or an epidural, you're basically inducing a temporary shock state from the actual degree of neurogenic effects that you're having. Depending on the level of it can become profound, and become so profound that actually it begins to affect heart rate, which is then you got a double whammy effect. You decrease your systemic vascular resistance, plus you decrease heart rate, which you decrease cardiac output, and then you've got a really big problem in your hands. The other things that also regulate vascular resistance are humoral regulators, such as angiotensin II, catecholamines that are released both in by the actual neurons, but also released by the adrenal medulla, such as norepinephrine, epinephrine. And under normal circumstances, ADH accounts for a very small percentage of vascular resistance, but when given in high enough doses, becomes, of course, our famous drug called vasopressin, which has a very potent effect on vascular resistance. Blood viscosity, and it basically does not require, the ADH vasopressin does not require a receptor. It bypasses the receptor. So it couples inside the cell and has the effect that it wants. So if you have a situation where a person is you think receptor depleted and giving them epinephrine doesn't seem to be working, vasopressin may be a good choice. Okay? Of course, blood viscosity we talked about, then ionized calcium levels also will affect vascular resistance. So what you're looking at, and this is a previous slide, so this is a really quick, brief discussion. If you look at your local regulators, you have electrical mechanical coupling, which is simply the concept that you have electrical activity that causes activation of the cell, and it causes ionized calcium to enter into the cell, the actual vascular smooth muscle, and causes a contraction to take place. You also have pharmacomechanical coupling, which means that you have a receptor site, such as a beta or an alpha-1 receptor activation. And when it binds to it, it causes a G-coupled protein to increase the release of phospholipase C activation, leading to increasing levels of inositol triphosphate, which then that causes the SR to release higher levels of calcium, and that also increases the vascular tone, as well as inducing via the G-coupled protein on this side a coupled calcium channel, which allows calcium to enter the cell. So two main mechanisms that calcium is important is one is extracellular, which is maybe accounts for about 15%, 5 to 15% of the actual overall calcium that comes in and causes contraction. Or the other more important part, which is in the SR, where the high amounts of calcium are located at, and they release it intracellular to have the effect that you want. So there's many different things that can cause this phospholipase C to get activated via these different kinds of protein receptor sites, leading to this activation and release of calcium inside the cell. Okay. As a consequence to this, you'll see that the tissue releases certain kinds of effects. Let's say surrounding tissue is being given oxygen and nutrients by this capillary network here. And if this cell becomes stressed, it becomes to release and increase levels of, say, nitric oxide or increased levels of hydrogen ions. These act as vasodilators, and what will happen is the arterial will vasodilate and allow more perfusion to hopefully uptake and give that tissue more oxygen and more nutrients that it needs. At the same time, if that tissue is actually healthy and getting enough oxygen, it'll actually release other mediators which will cause vasoconstriction. So this is a constant kind of regulatory mechanism that's taking place. Now, there's two things that are important by this example. One is that this concept is simply believes, which is not necessarily true, is that the cells themselves are the ones that are responsible for this autoregulation. That may be partly true, but the other thing that people have to consider is that this is also pulsatile-based, which is pulsations actually matter in the sense that these vasodilator areas, vasoconstricting area beds, will make a determination of how long they should stay open based on the pulses they get hit with. Okay? We do know that if you put somebody on cardiopulmonary bypass, everybody goes into metabolic acidosis. And we think that happens is when we put people on bypass, we no longer have pulsatile flow. It becomes continuous flow. And the lack of pulsatile effect means that if you have, let's say, 10 beds and they all have to perfuse at the same time, you would have hypotensive shock. So only 3 beds get actually perfused. The other 7 beds are closed down. Well, when you go on bypass, those 3 beds stay open all the time, and the other 7 beds basically stay closed. There's no reactivation. It doesn't sort of switch from one section to the next. And that becomes a problem for us when we're doing bypass procedures and stuff like that. The neural input eventually causes the sympathetic constrictor, causes the actual receptors to activate, causes the basal tone to be actually maintained. If you decrease the course of sympathetic activity, this system will shut down, and the person will begin to distend and have increase in capacitance. This becomes more of an issue on the venous side in the sense that once you go into shock states where you get neurogenic shock, the venous capacitance vessels will get very much larger. The arterioles have a certain amount to be able to hold capacity, but where you lose most of your volume, believe it or not, it's in the venous side, the capacitance vessels. So when you put somebody and give them a spinal, you're basically inducing a more profound venal dilation than you are arterial dilation. You still are causing the arterial dilation, but that's really not what's causing the shock. It's really caused by the venous side. That's why when we tell you give fluids, we're basically replacing the volume on the arterial side, more so on the venous side. The other, of course, mechanism that regulates blood pressure is your renin-angiotensin system. We've gone through this over ad nauseum, so I want to make sure that you still know it for the next test, because you should know this like the back of your hand by the time you get to clinical. Angiotensinogen is actually activated by, goes from its inactive state to its active state by renin. Renin is the enzyme that's being released by the kidney, and what actually activates the kidney are the increasing levels of catecholamines, low blood flow, certain degree of low perfusion, of course, to the kidney, and hyponatremia to a certain degree will cause a little bit of the renin to be hypersecreted. This causes the angiotensin 1 to be released. Angiotensin 1 then circulates into your venous circulation, goes through the lung, which then gets converted from angiotensin 1 to angiotensin 2 with ACE, which is the angiotensin converting enzyme that's located mostly about 80-90% in the lung. That converts now a activated angiotensin 1 to an angiotensin 2, which then has vasoconstricting abilities. Plus, it also goes to the adrenal and causes an increased release of norepinephrine, which causes more vasoconstriction. Angiotensin 2 also not only affects vascular tone, but it also increases the adrenal cortex to release increasing levels of aldosterone. Okay, aldosterone then goes to the kidney, tells it to retain more sodium. Sodium is then retained with water coming back with it, and increases potassium excretion, and begins to increase your total body volume. The other thing that increases your total body volume is that angiotensin 2 is also an activator of the ADH system in the central nervous system, so the hypothalamus releases that as well. So you have multiple effects of angiotensin 2 here. One thing that ACE inhibitors will do is they will inhibit bradykinin breakdown, and it will increase the bradykinin levels, increasing the prostaglandin level synthesis, causing vasodilation and increasing peripheral vascular resistance. And that's how ACE inhibitors work. They have a dual arm to them. They not only work as inhibiting 1-to-2 conversion, but they also increase the bradykinin levels, which decrease your blood pressure overall. Of course, your alterations in volume or controls sodium are things like aldosterone. Aldosterone is, of course, driven by epinephrine, angiotensin II. The other thing that also activates aldosterone is adrenocorticotropic hormone and hyponatremia. H1-natriuretic factor is also important in the sense of making the person diurese more by not retaining sodium. And what actually controls water is antidiuretic hormone, which is also by the brain. So now let's go on to hypertension. Okay, so that's the basics of high blood pressure is regulated. So let's go on to the next system, which is actually what we're going to talk about today, which is hypertension, which is a pretty common circulatory problem. It affects about 60 million Americans, which is a pretty large part of the population. Unfortunately, it leads to, if it's not properly treated, to long-term end organ failure. For heart, it usually develops cardiomyopathy, congestive heart failure, ischemic heart disease. Kidney leads to the most common cause of chronic renal failure. Neurological increases the risk of developing strokes or aneurysm, ruptures. And with this disease, you'll get no liver effects at all, though. Okay, the liver is pretty much going to be immune to the hypertensive effects until you develop the cardiac failure effects, which is a secondary problem. So the liver itself, though, is not affected really by hypertension. When you look at the definition of hypertension, it varies between textbooks because there's differences in determinations of what normal is in the sense of you can call it from stage 1 all the way to stage 2. Stage 2 is much more dangerous. Stage 1 is still considered hypertension, so anybody above 140 systolic pressure and anybody with a higher than diastolic pressure of 90 is considered to have hypertension. So 140 over 90, above that, you're considered hypertensive. If you stay in the stage 1, which is 140 over 159, to a diastolic between 90 to under 100, then you're looking at stage 1, which is a little bit more gradual in onset, it's more benign. When you go into stage 2, the disease will accelerate more rapidly and cause more likely the end organ effects, and that's what you really don't want to have. Some people will go very quickly into stage 2, and others will stay in a they get on a pre-hypertensive, then go into hypertensive stage, which is stage 1, and stay that way for 10 or 15 years before they get into major problems. But if you go into stage 2, within 5 years, you can get into major problems. So it doesn't take that long. Systolic hypertension now has been a better predictor of risk, and we used to say that it was always diastolic, but now some of the newer studies are coming out that actually systolic is really a better indicator of risk. The higher your systolic pressure, the more disease is more likely to be present. You should, yes, you have to both of them, usually most of the time. Okay. If you have one elevated comparison to the other one, that we used to call that isolated hypertension, it's really not. You have to, if it's got one or the other, it's considered hypertension now. You should be treated for it. Okay. In the old days, they said, don't worry about it unless your diastolic doesn't get above 90. That's not true anymore. Finding out that blood pressures are get above 140 is significant. So, the primary hypertension, also known as essential hypertension, has an idiopathic cause, which is we don't really know the main cause of it. As genetics is becoming more prevalent in medicine, it's becoming more understandable that it tends to be a higher predilection of genetic deficiencies that we're seeing in individuals. So there's some kind of a breakdown in the actual system anywhere along this path. It could be kidneys, adrenals, blood pressure, CNS. It's multifactorial. But we think it's a lot of it's due to genetics, which I think accounts for about 90% of the hypertensive patients have essential hypertension. They've also been associated with diabetes and obesity in individuals with primary hypertension. Secondary hypertension is something we concentrate a lot on because it's something that we usually are getting involved with. Okay? Essential hypertension is something that you're going to see the long-term family practitioner or internal medicine doctor taking care of this problem, and you have to sort of identify, is the person adequately regulated? They're going to be safe to do anesthesia with. But the bigger problem is when they have to come in for procedures to ameliorate or basically get rid of hypertension, which is how we get involved, which is like in secondary hypertension. Things that account for the most of the counts of secondary hypertension is chronic renal failure or chronic renal disease, just like pyelonephritis, glomerulonephritis, or diabetic nephropathy, which accounts for about 2 to 4% overall hypertensive diseases. Primary aldosteronism will also be seen in about less than 2%. Renovascular disease, which means renal artery stenosis, which is where we actually put stents in, will be called down to radiology to help in those kind of situations. And you got to be sort of ready when you're doing these kind of procedures, because when they put the stents in, all of a sudden perfusion increases, and all of a sudden you have an acute drop in blood pressure because the renin drops off very quickly. You can also have diseases that hopefully you'll never get involved with, which is pheochromocytomas. These are pretty much tumors of the adrenal that can secrete very high levels of norepinephrine or epinephrine into the bloodstream and cause very rapid fluctuations in blood pressure. In the old days, patients that had pheochromocytoma that was undiagnosed at the time of the operating room and it was manipulated had an 80 to 90% mortality rate. The good thing is that now with the medications that we have available, we can blunt pheochromocytoma pretty aggressively and have it under control pretty quickly. So most of the time mortality is dropped down significantly in that. The other thing that can also account for secondary hypertension would be coarctation, which is narrowing of the aorta, and usually the descending aorta, usually right after the subclavian, causes decreased renal perfusion and drives up the renin-angiotensin system up. When you repair this problem, usually the biggest problem you have afterwards is to try to keep the blood pressure going, because all of a sudden you don't have enough angiotensin II being produced anymore. Hyperadrenocorticism accounts for what's called Cushing syndromes, can also account for this. Drugs and intracranial hypertension will also cause secondary hypertension. When should it be secondary? Well, the patient's usually outside the normal range. Usually most people that come in with essential hypertension start at the age of between 20 to 50. The people that are younger than that or older than 50 are usually secondary hypertension, and you've got to start looking for the different causes at that point. So severity usually is more severe. The onset's usually more rapid with secondary, and usually has associated symptoms, signs and symptoms. And a lot of times these people have lack any family history of hypertension. So these are the things that you would tend to see that will actually cause impairment of and cause effects in blood pressure by impairing the natriuresis. You can actually have genetic predisposition, like we talked about, things like hyperinsulinemia, Mendelian hypertension, which is basically genetically driven hypertension, where they have increased risk of developing mineralocorticoid excesses for some people. There's actually, of course, a different subgroup of individuals. There's groups of individuals that are type A and type B personalities, and that has to do with how their actual internal hormonal systems are set up. Type A personalities tend to be much more hypervigilant. They tend to be, little things tend to bother them a lot more. They tend to be pretty driven. Versus type B personalities don't have that problem as much, and they don't have as much hypertension. If you look at actual mortality rates for individuals for cardiovascular disease, you're looking hypertension, more likely to develop an MI, or type A's. Type B's are more likely to be more sedentary, more not likely to develop that as long as they don't develop the morbid obesity problems that sometimes associated with it. But it doesn't mean that people that are type B are sloths. It's not that. It's just the way they look at things is very differently, and the way they release the things like epinephrine and norepinephrine is very different. They actually usually release less of it. And then you have people, of course, on the other extreme that are above type A's, which are the panic disorders, which actually are releasing too much into their bloodstream. And that puts them at a very, very high risk for having problems. So we think that's people are like in a continuum. There's not just one set point. And that continuum falls into the higher side, then you end up in developing hypertension. So all these things can actually cause this effect. Treatment, of course, is weight reduction, exercise, smoking cessation, low sodium diet, and drugs. We should do mostly the first four and really try to stay away from the drugs as much as possible. Unfortunately, most people want to just have the magical pill to instead of changing their habits. Just to tell you how difficult it is to change one of these is if you've never exercised in your life, okay, I would tell you, say, okay, go into an exercise program and tell me how many of you are still doing it after a year. I'd say 99% of people that would never done exercise before, after about a year of doing it, then left alone, they have no other stimulus, would go right back to being sedentary again. They don't really enjoy it. People do what they enjoy. Okay, so if you're going to give somebody a helping hand with something, make sure that whatever it is that they can do to weight reduce by exercising somehow, make it fun for them. If they like dancing, make them dance. If they like to run, make them run. If they like playing soccer, that's what they're going to like to do. If you make a guy that wants to play soccer, walk on a treadmill, forget about it. It'll last for a few months, but pretty much unless there's an incentive to do it, it won't work. So, and you'll see that with most people in life. Now, one of the things that if you can't get the lifestyle modifications and not at goal blood pressure, because most of the time, if you take the person and you change their body by changing their diet and changing the way they exercise, most people will not have blood pressure problems. That's even people that have essential hypertension. If you activate them to exercise back to normal, the actual blood pressure will come back down to a more normal level. So most people with essential hypertension have ways of doing things without having to receive treatment. Now, one of the important factors of that is exercising to the point that you're actually increasing your cardiac output to a high level. And immediately after you exercise, or while you're exercising, your blood pressure soars. Okay, it increases quite a bit. And if you look at somebody who's a runner, heart rate goes from, let's say, 55, steady at state, they're going up to 80, and their blood pressure goes to 120, it goes up to 160. And you're going, wow, that's hypertension. But no, that's normal cardiovascular response to stress. Now, what's really cool about it is after you run for, let's say, 45 minutes to an hour, when you shut down and you relax, okay, your body goes into a profound that's not the right word. Your vascular resistance drops off dramatically afterwards, okay? So your blood pressure, instead of being at, let's say, 120 over 60 at your normal, now that individual is down to 100 over 55. And that doesn't stay like that for half an hour. We're looking at 4 to 5 hours long. Okay, so and we think the reason that happens is because your body is redistributing blood flow to all the tissue that was going a little bit anaerobic on you. Okay, so exercise is actually inducive of vasodilating you and putting you into a more better set point. And we think that's one of the important factors of lifestyle modification. And there's a lot of good research that's coming out in the last few years saying that you need to maintain a very high level of point of exercise to get that kind of effect. But let's say the blood pressure is still not regulated after that. What do? And what they do is, if you're an internal medicine doctor or family practitioner, you'll get the person on initial drug choice. If you have it without any compelling indications, which means that there's nothing really bad side effects, and you'll start usually with blood pressures of 150, which is stage 1, with thiazide type diuretics. Almost everybody comes in with a thiazide diuretic. Okay. A lot of people then may be considered put on ACE inhibitors, and now they are also considered to be put on ARBs, which is like losartan. It can be a nightmare for us. If the person is in a higher stage 2 hypertension, usually 2 drugs are required. So one of the things I always look at is how many antihypertensives is the patient on. If the patient's on only 1, it's not going to be a problem for us usually. But if the person is on 4 different antihypertensives, the guy's on a beta blocker, he's a diuretic, he's an ACE inhibitor, he's on direct vasodilator, he's also on nitroglycerin. You're looking at multiple drugs that are trying to hit different portions of the actual circulatory mechanism to shut it down, and also the renal system. So that it tells you there's more impairment. Okay, and that's what you need to have in the back of your mind. So additional drugs can have much more serious consequences when you put these people to sleep. Now, the antihypertensive drugs we're going to go over real quick is the diuretics. We're going to go over the 4 different kinds of diuretics that I want you to sort of know about: sympatholytics, vasodilators, and the renin-angiotensin system. This is basically used, this table here is to show you all the different meds you sort of have to know about, because when you get to clinical, you're going to have to know them even better. And this is the first stage. I sort of want to introduce you here. And then next coexisting course, when you take this course again, you'll see this kind of slide again, but we're going to give you more detail and more, I expect you to know more of it. So I'm going to keep building your knowledge up on antihypertensives. I think is kind of important. Remember, the way that we're trying to do is we're actually inhibiting somewhere in the mechanism these drugs, and this is sort of gives you an overall view of where you can actually inhibit the system, and sort of go this over on you a little bit on your time, showing you the kidneys, how the renin-angiotensin system is affected, how the vasculature can be affected by vascular smooth muscle, or as well as the angiotensin receptor inhibitors, how the heart's being affected by these medications. So every single drug has different effects. Let's go into the actual diuretics first. The first diuretic is a thiazide diuretic. The typical example of that is hydrochlorothiazide. It's the most common one used. It's usually a primary agent used, and the mechanism of action is to inhibit sodium and chloride reabsorption not only in the loop of Henle, but also in the distal convoluted tubule. As a consequence, what it basically does is it inhibits sodium reabsorption, and then water stays inside the actual tubule, and the person will begin to diurese. Okay, so you are going to get complications with it, which is you can get significant hypokalemia, hypomagnesemia. You can also increase the risk of this person developing gout because they develop hyperuricemia. Hypercalcemia, alkalosis may also develop. Hyperglycemia is another issue with this. And the other thing that may also happen is if you have somebody on lithium, you have decreased lithium clearance. The potassium-sparing diuretics, there's two kinds. There's the epithelial sodium channel blockers, which is amiloride, okay? And the other one, which is aldosterone antagonist, which is spironolactone, which I'll talk about next slide. The mechanism of action of these agents is to block the sodium channels and basically inhibit sodium reuptake as a consequence in the tubular lumen, and causes complications such as hyperkalemia, hyponatremia can also develop, and much more serious complication of these agents include megaloblastic anemia and dermatitis. If you look at the aldosterone antagonist, which is basically a potassium-sparing diuretic, okay, but the way it works is by inhibiting with the aldosterone binding sites, okay, which is why spironolactone is a lot of times used for patients with have liver disease where they have already elevated levels of aldosterone and increased sodium retention. The complications with that, of course, because it is a potassium-sparing diuretic, is hyperkalemia. The other downside to it is that spironolactone will bind to other receptor sites, which will induce gynecomastia. Some individuals will get mental confusion, ataxia with it. And this is what I saw the other day, was somebody who was put on spironolactone and they developed Stevens-Johnson syndrome. And everybody else, they hadn't picked up on it and actually had to call the doctor about it. They thought it was from some other kind of weird disease. And I said, this skin looks like Stevens-Johnson syndrome, so I looked it up. And sure enough, the patient was on spironolactone, and something you want to avoid. So every once in a while, sometimes even reviewing this stuff kind of gives you a helpful reminder. Loop diuretics are something that we use very, very frequently. Things like furosemide, also known as Lasix. The mechanism of action is it inhibits the chloride reabsorption first, and this basically leads to an inhibition of sodium reabsorption in the loop of Henle, and basically inhibits the whole loop of Henle from being able to concentrate urine, and the person will begin to diurese pretty effectively. It's actually a much more potent diuretic than the other ones that we've talked about. The biggest complications of loop diuretics is you can develop hypokalemia, and a certain degree of metabolic alkalosis can also develop. The carbonic anhydrase inhibitors, the best one example of that is acetazolamide. The mechanism is basically prevents the formation of carbonic acid in the distal tubule. It decreases hydrogen ion secretion and inhibits the sodium-potassium antiport mechanism. So what you'll see in this consequence is it decreases sodium reabsorption, and that leads to a diuretic kind of effect. It's not as potent as a loop diuretic. What it does do is that it induces a metabolic acidosis in a patient, and can cause CNS depression, drowsiness, fatigue, and sometimes paresthesias, and also very severe forms of diarrhea at times. And go on to the next agent, which is sympatholytics, which is the second. So when I go from diuretics to sympatholytics, The sympatholytics, you have to look at beta blockers. Okay, beta blockers basically bind to beta 1 and antagonize their effects. So, and that's mostly in the heart and in the lungs. So it's going to cause, if you slow down the heart too much, you're going to induce the person to go into congestive heart failure. You can go into severe bradyarrhythmias and inducing somebody almost into a sick sinus strait, and you can go into complete heart block. Bronchospasm can also be occurring because, of course, beta 1 is not selective only to the heart. It may actually be also affecting the lungs, so it can cause bronchospasm. It will mask the hypoglycemia because you won't get the tachycardia associated with hypoglycemia, and the person won't get as jittery with it. So it's one of the things that beta blockers will hide somebody who's diabetic when they're getting hypoglycemic. It also will make sometimes the Raynaud's phenomenon more prevalent. A person can become sedated with it. A lot of people that put on beta blockers don't feel well. They feel they're tired. They'll tell you that they feel sleepy, which is not a good thing, and decreases their overactivity, which is something you not necessarily want to do. It really affects their lifestyle. And you get rebound angina when you discontinue it, which is a real big downside. That's why we always tell you, are the person taking the beta blockers, are they taking it within 12 hours of the operation? We try to always give the person a beta blocker within 12 hours. So that's one thing you'll see when you get to clinical as well. You have sympatholytics that are combined alpha and beta effects. The best example of that's labetalol. The labetalol comes in 5 milligrams per milliliter as a dosage. Its main mechanism is that it blocks alpha-1 as well as beta-1. The complication is you got to be really careful with labetalol when you co-administer it with with epinephrine. Epinephrine is a very intense alpha vasoconstrictor, and labetalol tends to inhibit the beta sometimes a little bit more profoundly, and you can get unopposed vasoconstriction and you get cardiac arrest from it. The person will go asystolic on you when you combine epinephrine and labetalol. So just be careful with it. It's not the treatment of choice. If you have somebody with hypertension induced by epinephrine, you don't pull this drug out. It's not a wise one to use. There's other things you should use instead. Sympatholytics are alpha-2 agonists. This is clonidine. Basically, it works by activating the alpha-2 receptors, which are usually presynaptic. Their preferred function is to inhibit the release of the norepinephrine vacuoles, so you will get accumulation of the vacuoles within the presynaptic membrane area. As a consequence, this person will have a very high degree of rebound hypertension if you discontinue this medication, which makes it dangerous. If the clonidine gets into you essentially, which it normally does, and if you have a reduced blood-brain barrier, which you normally have in the elderly patients, clonidine is really a very, very bad choice in somebody who's over 70 years of age. You can severely sedate them, and you can have people that won't wake up on you at the end of the case. And we've had that happen here before. The reason that we know that is because we were in the 90s, they were trying to push clonidine as a new drug to use for nausea as well as for pain, which is a great drug in that sense. It also helps with pain regulation, but the downside is that on 80-year-olds, it just causes way too much oversedation. So in Naples, we almost never use it at all. Sometimes you'll see it used in Tampa, but it's still got so many other bad side effects that it's really gone down in its utilization. But still, you should know what alpha-2 agonist is, which is clonidine. The vasodilators that we use very commonly now are calcium channel blockers, amlodipine, which is nifedipine is the other name for it. The main mechanism of action is basically binding to calcium channels, and of course calcium channels are important for contraction, like we showed you in the prior slides. The complications with this, if you give too much of the calcium channel blocker, you can cause the AV node to be completely blocked out and cause complete heart block in some individuals. Sometimes tachycardias will become evident because you'll actually cause a reentrant arrhythmia to take place. So like WPW will be induced into a SVT and go into VTAC possibly when you give Rapamil to that individual. Congestive heart failure, weakness, hepatic dysfunction, and syncope can also occur with these agents, although more rarely. The vasodilators now include hydralazine. The basically action of is direct vasodilation. They increase the cyclic GMP levels, and the arterioles then dilate more than the veins, so this is considered more of an arterial vasodilator. The complications with this is that it causes a reflex tachycardia and may sometimes cause a lupus-like effect and fever. Be very careful when you use this drug because you need to go with it easy. 2.5 milligrams IV is the first primary dose, followed by 5 milligrams after 15 minutes if you don't see any deleterious effects to maintain blood pressure regulation. Then you wait every 15 until you had another 5. So sometimes it takes a little bit of time to get the blood pressure control with hydralazine. The renin-angiotensin blockers, there's two kinds. There's, of course, the renin-angiotensin blocker, which we call the ACE inhibitors. They're called captopril. They basically prevent the conversion of angiotensin 1 to angiotensin 2. The downside of complications of this drug is that it can induce hyperkalemia and proteinuria. If the person begins to develop cough, there's a very good chance that this person within the next 6 months will develop angioedema. So if you have somebody's on ACE inhibitors and also starting developing a cough, it may be a precursor sign that you're getting bronchial edema, and that person may ongoingly develop what's called angioedema, which is an airway nightmare, which we'll talk about later on. Then you have the angiotensin receptor blockers. The angiotensin receptor blockers is losartan. Its mechanism of action is to block angiotensin 2 receptors. Again, they also will cause complications such as cough and angioedema. The reason I don't like these agents is they're too powerful. They knock out everything, and as a consequence, these individuals will get very profound hypotension on induction of anesthesia. So I would basically hold these medications. It's one of the few ones that I would tell you definitely hold no matter what, is angiotensin receptor blockers. We did one the other day, and sure enough, as soon as we put the person to sleep, blood pressure dropped like a rock. So we had to support him the whole time. It's just one of those things that's really, you want to sort of avoid it if possible. Now, what about a hypertension disorder? What do you see as for organ dysfunctions? Well, you'll see orthostatic hypotension, because very many people that are hypertensive become hypovolemic. Okay? Because literally the arteries get squeezed down and the volume is very depleted. So when you put these people to sleep, they vasodilate and crash on you. They will have an increased risk of ischemic heart disease, an increased risk of strokes, increased risk of peripheral vascular disease, and increased risk of developing hypertensive kidneys, which is nephropathy, and chronic renal failure. Hypertensive crisis is the most serious complication of hypertension, which is a diastolic pressure over 130. If you have this person come in like this person should not be discharged to home. This person should be discharged to an ICU where they need to be monitored. Okay? Usually it's a sudden acute attack. Usually most of the time it's because somebody decided not to take their medications. And it can become a nightmare in your hands, especially clonidine. It's usually will be associated with some kind of end-organ dysfunction, and you get a rapid deterioration in this individual unless you get the rapid cure or rapid treatment. The causes of this, of course, could be all these, which is essential hypertension that went out of control. Renovascular hypertension is another possibility where the person all of a sudden has occluded more of their renal artery. Withdrawal from medications, the big ones are clonidine. The other one I've seen where it's Procardia XL also will do this. Drug ingestion such as cocaine will induce this as well. Patients that develop preeclampsia go into eclampsia will cause hypertensive crisis. I've seen a woman go into full-blown pulmonary edema from eclampsia. It's pretty impressive. Head injury patients will do this as well. Fios chromocytoma, which is adrenal tumor, will cause this. Guillain-Barré syndromes will sometimes cause this, although they're pretty rare. Spinal cord injury, it's a delayed action, which is the autonomic dysfunction problems, which we'll talk about in a little bit, and which is autonomic dysreflexia that will cause the issue. Treatment of hypertensive crisis is to initiate usually nitroprusside. Most of the time, I would always consider putting an A-line in these individuals, and definitely do not give ACE inhibitors in patients with hypertensive crisis, because usually they have very elevated levels of angiotensin 2, and you give them an ACE inhibitor and you'll drop them. You'll basically lose your blood pressure and you'll have big problems in your hands on that. Instead, you want something that's titratable but rapidly titratable. So nitroprusside is usually the agent of choice. The other thing you need to consider is cardine, which is a calcium channel blocker, which has also been used recently and has been found pretty effective. Okay? You can actually go through these different algorithms that they have available for you. Now, this is the last one, is a table. And not that I always agree with every table that you see. One thing that I definitely do not agree with is when they show you here in aortic dissection. I agree with the beta blocker, but I don't necessarily agree with the nitroprusside is a good choice. Nitroprusside will tend to give you a decrease in airflow that's too rapid, and a lot of times we'll get reflex tachycardia. So when they put it as a beta blocker up front, that's fine. But if you forget that and you start nitroprusside by itself, you can actually induce the dissection to occur more rapidly. So I tend to use labetalol myself as my primary agent in this kind of situation, and it works very, very well. Okay, so it's one of the things that I disagree with. Everything else I pretty much agree with here, because again, clinical experience dictates to me sometimes things work. Okay, all right, that's it on that.